Let's jump straight into this clinical review of high-yield cardiovascular infections and hardware complications. We're zeroing in on the exact next best step decision logic you need to master for Step 2 CK. No fluff, just the high-yield facts.
Here's our agenda for today. First, the infective endocarditis workup. Second, rheumatic fever prevention. And third, prosthetic valves and stent thrombosis.
Starting with Section 1, the infective endocarditis workup.
Okay, picture this clinical vignette. A patient presents with a fever, a brand new regurgitant murmur, and those classic, non-tender macular Janeway lesions on their palms and soles. So what's your next best step in management? Well, assuming the patient is hemodynamically stable, you absolutely must obtain multiple blood cultures before starting any empirical IV antibiotics. Seriously, do not reach for the antibiotics first. Getting those cultures drawn is an absolute prerequisite. It's the only way we can ensure targeted, effective therapy later on.
To actually lock in that diagnosis, we rely on the modified Duke criteria. You're mainly hunting for two major criteria here. Number one, typical positive blood cultures. Think Staphylococcus aureus or viridin streptococci. And number two, an echocardiogram clearly showing a valvular vegetation. Now, for the echo, start with a transthoracic echo, or TTE, but you'll want to upgrade to a transesophageal echo, a TEE, if the patient has a prosthetic valve, an implanted device, poor acoustic windows, or if your clinical suspicion remains super high even after a negative TTE. As for the minor criteria, keep an eye out for a predisposing cardiac lesion, IV drug use, fever, or those classic embolic and immunologic phenomena.
Now, these specific organism-to-risk links are incredibly high-yield for exams. Let's break them down. If the culture grows Staphylococcus aureus, you should immediately suspect IV drug use, intravascular catheters, or implanted devices like pacemakers. What about viridin streptococci? That classically follows dental manipulation. Then we have the Hasek organisms, which are closely linked to poor dentition or periodontal disease. If you see Enterococcus, think urinary or gastrointestinal source. And here's a big one, Streptococcus galoleticus. This organism strongly correlates with colon carcinoma, meaning a positive culture should prompt an immediate gastrointestinal evaluation.
Let's contrast right-sided versus left-sided endocarditis, because this really helps build the clinical picture. Right-sided endocarditis almost always involves the tricuspid valve and is tightly linked to IV drug use, usually with Staph aureus as the culprit. But here's the catch. Instead of those classic peripheral signs, these patients usually present with septic pulmonary emboli. You'll see these as nodular opacities on a chest CT. On the flip side, left-sided disease hits the mitral or aortic valves. This is where you'll see those peripheral and systemic embolic manifestations, things like a stroke or a renal or splenic infarct.
So when do we actually escalate to surgery? Well, there are some pretty strict thresholds. Major indications include acute heart failure driven by severe aortic or mitral valve regurgitation or frank valve destruction. Another massive red flag is a perivalvular abscess. This often sneaks up clinically as a new conduction abnormality or heart block. You also want to consider surgery if there's persistent bacteremia despite using the correct antibiotics, or if the patient has huge vegetations that keep throwing off persistent septic emboli.
Moving on to prevention. Antimicrobial prophylaxis, usually amoxicillin, is indicated for high-risk procedures like gingival manipulation. But, and this is a big but, it's only for high-risk patients. We're talking about folks with prosthetic heart valves, a prior history of infective endocarditis, or certain congenital cyanotic heart diseases. If it's a low-risk procedure and there's no active infection, do not give prophylaxis. It's just not needed.
Section 2, rheumatic fever prevention.
Let's look at another scenario. A school-aged child comes in with a fever, migratory polyarthritis, and an elevated ESR. Oh, and this is happening a few weeks after an untreated sore throat. You probably know exactly what this is, right? It's acute rheumatic fever, triggered by a prior group A strep pharyngitis infection. The key takeaway here is simple. Treat group A strep pharyngitis promptly so we can prevent this exact outcome. To diagnose acute rheumatic fever, we use the Major Jones criteria. You need evidence of a preceding strep infection plus either two major criteria or one major and two minor criteria. The major ones include migratory polyarthritis, carditis, Sydenham chorea, erythema marginatum, and subcutaneous nodules. The minor criteria are your supportive findings, things like fever, arthralgias, and elevated CRP or ESR, or a prolonged PR interval. And remember, if this progresses to chronic rheumatic disease, it classically damages the mitral valve.
Now let's zoom in on Sydenham chorea for a second. The pathophysiology here is actually driven by molecular mimicry.
What happens is the antibodies your body formed against the group A strep infection get confused, and they start cross-reacting with neuronal antigens in the basal ganglia. Clinically, this looks like involuntary, jerky movements that, interestingly, get worse when the patient is awake or trying to move. You'll also see hypotonia and emotional lability. To evaluate this, you'll need throat cultures, anti-strep titers, and a full cardiac workup to check for concurrent carditis.
To stop secondary attacks of rheumatic fever in their tracks, these patients need long-term antibiotic prophylaxis. We use long-acting intramuscular benzathine penicillin G, but the timeline depends entirely on the disease severity. Here are the rules. Uncomplicated rheumatic fever? That's 5 years or until age 21. If they had carditis but no permanent valvular disease, it bumps up to 10 years or until age 21. But if they had carditis and they now have permanent valvular disease, like classic mitral stenosis or regurgitation, they are looking at prophylaxis for 10 years or until age 40, whichever is longer.
All right, Section 3, prosthetic valves and stent thrombosis.
When you're evaluating prosthetic heart valves, you have to differentiate between mechanical and bioprosthetic valves, purely to get the anticoagulation management right. It's a classic trap. Mechanical valves are highly thrombogenic. They absolutely require lifelong anticoagulation with warfarin to keep clots from forming. Bioprosthetic valves, on the other hand, are way less thrombogenic. For those, usually only need antiplatelet therapy with aspirin.
So, how does prosthetic valve dysfunction actually present? You're looking for transvalvular regurgitation, a paravalvular leak, or valvular obstruction from a thrombus. Clinically, be on the lookout for a new regurgitant or stenotic murmur, sudden heart failure, or even macroangiopathic hemolytic anemia. Now, if a prosthetic valve thrombosis throws a clot, it can cause severe thromboembolism. For instance, if that embolus causes acute limb ischemia, remember your 6 Ps: pain, pallor, paresthesia, pulselessness, poikilothermia, and late paralysis. If you see that, start IV heparin immediately and grab a Doppler to assess limb viability. Or, if the embolus leads to symptomatic carotid stenosis, you'll want to consider a carotid endarteriectomy for 70 to 99% occlusion. Ultimately, the diagnosis of the underlying valve dysfunction itself is confirmed with an echocardiogram.
Let's try another vignette. A patient who recently had a left anterior descending stent placed shows up with acute chest pain and ST elevations in leads V1 through V3. What is the absolute strongest predictor for this acute event? Well, the diagnosis here is stent thrombosis, which is causing a fresh infarct right in the same territory as the stent. And the strongest predictor for this? It's the premature discontinuation of their antiplatelet therapy.
The structural reason behind this thrombosis risk really comes down to the type of stent. Bare metal stents undergo what we call early endothelialization. This means the patient's native cells cover the metal pretty quickly. That gives you a shorter thrombotic risk period, but a higher risk of future restenosis. Drug-eluting stents do the opposite. They prevent that rapid cell growth to lower the risk of restenosis, which causes late endothelialization. Because of this, the synthetic stent sits exposed to the bloodstream for much longer, significantly extending that high-risk window for thrombosis.
Because of that risk, we have very strict guidelines for dual antiplatelet therapy, or DAPT. These patients need DAPT, which is aspirin plus a P2Y12 inhibitor, for a bare minimum of 6 to 12 months after either bare metal or drug-eluting stent placement. After that, they stay on low-dose aspirin indefinitely. If they need elective surgery, you defer the procedure until that minimum DAPT duration is totally complete. Taking them off antiplatelet agents early is absolutely incorrect. And just to briefly contrast this with other vascular issues, remember that peripheral artery disease is initially managed with supervised exercise, smoking cessation, and cilostazol before you even think about revascularization for an ABI of 0.9 or less. And chronic venous insufficiency? That's managed with leg elevation and compression. But for your post-stent patients, strict adherence to that DAP timeline is non-negotiable.